Good morning, everyone, and welcome to the NHIA BAM Pilot Office Hours. I hope you all had a great holiday season and enjoyed some quiet time. So today, I just want to encourage people, please put your questions ahead of time into the chat. Our updates over the last couple of weeks are a little bit shorter, so I don't want you to wait to the end to put questions in, because we did have some folks last time that hadn't put them in and kind of missed the window. So make sure you put your questions in as soon as possible, and we'll get to those at the end. And I have Bill Noyes on the phone today to take any of your reimbursement questions, and then we also have Ryan Garst. So Ryan, I'm going to turn it over to you.
Hello, everyone. Good morning. So quickly, we're just going to go through a couple of updates on the program. Nothing very, again, this is your time, but we just wanted to do a couple of quick updates. Talk a little bit about data collection and allocation again. We had a couple of changes and updates there. And then I did want to put some references together because we've gotten many questions over the course of the last couple of weeks about with the vaccine becoming more available to long-term care facilities and the administration of MABs at the same time. So I put in a reference from the CDC that you'll see on the slide. So we can go forward, Jen. So just want to give an update. The response and the enrollment really from our membership and non-members even has been really fantastic. We have 160 individualized brick and mortar pharmacy locations enrolled in the program. That is a response that not only we are completely enthused about, but that HHS and ASPR and all the Operation Warp Speed are really seeing that we were able to mobilize this very quickly over the course of the last 3 to 4 weeks and really get a lot of folks involved. So kudos to everyone that's involved in the program. And if you're not involved in the program and you're on the call and you want more information, you can reach out to NHIA. But just really a great representation of what our industry is and what we can do. We did have some infusions. I know for many of you that were involved from the very beginning, there was the first couple of weeks, some delays with getting the product to you with ABC and such. But over the last 2 weeks, the week of Christmas and the week of New Year's, which are shortened weeks, which are holiday weeks, which everyone's busy, we did, you all did 35 infusions of BAM. And that is really very surprising, a really big number, I thought, with the holidays. And we know that people are doing more and more and getting things aligned and mobilized to do more with the facilities in your area. So that's really great. And from what we've heard, the majority of those infusions have gone very, very well. No major issues, no major side effects and such. And then just to give you a general idea, almost 2,900 doses have been allocated through the first 3 weeks of the program, which is really spectacular. We were long-term care in our pilot was featured this week in the ASPR HHS Outpatient Therapeutic mini-series, which for many of you, I did send out a link to that mini-series to join. It's an hour, I believe, on Wednesdays. Around 1 o'clock Eastern time, where they have different people come in and talk about, the monoclonal antibodies, the vaccines. And this week was about long-term care facilities and the vaccine. So if you didn't get to see that, they do post it on their website. And if you have trouble getting a hold of that, I don't think it was posted as of yesterday at the end of the day, but it may take a couple of days. But that was a really good discussion that they had. You can move forward, Jim. Okay, and so the data collection, I just want to give everyone a big thank you for everyone that was involved. I appreciate you all getting the data collection tool back to me very quickly. We'll be sending out again today the data collection tool again for this week, which again would be Monday, which was the 4th or 3rd, I believe the 3rd, through Sunday, which will be the 10th. So we'll need all of the data returned there. And also, I know many of you have gotten back to me and said that you don't need any product for next week, that you still have enough on hand. But if you do and you've changed your mind, please email me, Ryan.Garst at nhia.org. by 3 p.m. Eastern today, and I can get you on the allocation list for next week if you do need more product. One update to the data collection tool that I need and that we've made is here shown on the second tab where you're entering in the facility information in which you've infused product at. I do need to know the number of doses administered at that facility. So for example, if you go into 3 different facilities and you're doing 5 infusions at each, I would need facility A, 5 infusions, facility B, 5 infusions, facility C, 5 infusions for your total of 15, for an example. That's information that I do need to get back to HHS for the pilot program. That's information they require. This last week, I was able to fill it out for the locations that have infused because you did provide that either in the email or you've put your patient data, which is part of the second tab, which is not shown here. So that's great. Another big question that has come up that Jen and I have gotten is the use in alternate sites. So for example, if you get a request from a federally qualified healthcare facility, or you get a request from a physician's office who's going to set up a certain day to do the infusion in their office for patients that maybe they have treated or tested, I should say, that have tested positive, please contact Jen and I. There is an alternate pathway request for allocation outside of our pilot. Again, this pilot is just for long-term care facilities, but if you do indeed have the ability to partner for other, if it's maybe a prison or again a federally qualified healthcare facility or again a physician's group that's going to be wanting to do infusions maybe in their office and have you come in and do the drug and the nursing, whatever that may be, please let us know and we will work on getting you a pathway to HHS for alternate product that can be used in those settings. We can move forward, Jen. And the last thing I wanted to talk about is we have gotten a lot of questions regarding the administration of monoclonal antibodies and vaccine. So I've listed here the interim clinical consideration and guidance from the CDC. Essentially, it's a 90-day period. So this is exact wording that I pulled out of the guidance, and there is the link as well there that takes you directly there. There's a lot of good information there, so you could take a look at it. But in terms of administration of monoclonals and the vaccine, it needs to be about a 90-day waiting period. So essentially, but you can read this here. I'm not going to go into the detail or read it off the screen, but this is information that we have had questions over the last couple of weeks that I wanted to make sure that was provided and got out there for you. So, and Jen, I think that's it in terms of what I wanted to go over really quickly, and so we could open it up to questions.
All right, we have a lot of questions today. All right, so first, can we just clarify? I can take this question. This question is really about, is it only the pilot only for Medicare patients in long-term care and SNF facility are also commercial payers? So you can use, commercial payers are fine. Medicare, Medicaid is also fine. You just have to run through your normal intake process. You can't bill Medicare for a commercial payer or a Medicaid payer. So that's where we've talked about running through your normal intake process. Bill, anything to add on that?
I would agree. You've got to run through your normal intake process to identify whether or not it's covered, at what rates, and what qualifies the patient. I have heard directly from some commercial payers looking to set a rate and looking to understand why the rate should be different than what Medicare has set for monoclonal antibodies, that one-on-one going to the patient in their home versus the patient coming to you. So I know that they are at least evaluating it, and I think that some have started coverage. I don't know at what rates. So I would agree with going through your normal intake process, payer by payer.
Thanks, Bill. I think here we have a recommendation for a diagnosis code for BAM pilot patients. Bill, do you know the diagnosis code for that?
I do not.
Okay. Let's see.
I do not, and it's not stated on the emergency use authorization. As far as Medicare goes, the documentation required is that the patient test positive and the dose is given within a certain time frame, and that they meet one of the high-risk conditions. There's nothing in there regarding specific diagnosis code, although I understand that you would probably want to submit a diagnosis code on the claim.
Right.
And everyone in the well, now it's not showing up. Sorry. Let me put it in the chat. I just found a link to a document that's from the CDC website that talks about some diagnosis codes for official coding and reporting guidelines, April 1st through September 30th of 2020. I just put the link to that document in. I honestly, I'm just doing a very cursory review of it, but it does have some information on diagnosis. So it may not be exactly, but we'll try and take a look too and come up with that answer. But take a look at this guideline that I just tossed out there in the chat. That maybe help a little bit more.
Thanks, Ryan. And this question is about the vaccine. If we have been hearing anything different from HHS regarding the vaccination of healthcare professionals. It is a state by state, it is challenging. I don't know of any states though that are not putting healthcare professionals who have direct contact with COVID patients as part of their first wave. It's just you have to work through your state process to figure out how your team gets that. And so it's going to vary from state to state, but I don't know of a state that is not putting healthcare workers who have direct contact with COVID patients in part of the first round. Now, that's not your pharmacist team. That would be your frontline nursing team that would be administering this, or going into the homes of potentially positive COVID-19 patients. So I would just encourage you to, reach out to your states. I know, for instance, on my nursing license, I was actually sent a notice from the health department based on the fact that I have a nursing license in that state, and I had to fill out a form associated with, if I needed to get the vaccine, associated with what my job description was. So again, I think it's different from every state. Ryan, have you heard anything different with that?
No, but I wanted to piggyback and add that also to check out the county health departments that you are also located in. So where your brick and mortar pharmacies are, because some of the states have been deferring to the county's health departments for prioritization of patients, or I'm sorry, for vaccines. So like, for example, in my county and in the state that I live in, the state is deferred to the counties to have people go in and register, and you have multiple different options to register. You're a physician, a pharmacist, a nurse, and then you have, so there was like a registration process that you can go in and self-register, and then they'll contact you when the phase for you for your position, I guess you could say, opens up. So some states are doing it by the state, some of them are using their county health departments. So just that's another thing that we're seeing. I do know that in terms of allocation for the monoclonals, that they are working on a direct ordering process, that they're not there yet. And when I say they're not there, I mean more like HHS and ABC, where people will be able to go in and directly order the monoclonal antibodies from the wholesaler. They haven't said that same thing about the vaccine, but as we've seen, the initial rollout of the MABs was a little bit of a challenge. We've seen that the initial rollout of the vaccine has also been a little bit of a challenge. So I know that they're listening to feedback, and we're having conversations with them. not specifically about the vaccine, but just, about how can things be improved and utilize maybe some current pathways that are already in place for drug distribution in the country. So I think they're listening. I know, like I said, probably in the next month or so, I would imagine maybe there may be changes in the MAB distribution. So hopefully, they'll learn from that and maybe see what happens with the vaccine.
Thanks, Ryan. This is just a question of any prospects with getting the Regeneron MAB product to be infused in the home. The Regeneron product is just not included in this pilot. I mean, you can talk to your state health department and your hospital systems and get the Regeneron product and use it for home infusion. It just would not be part of this pilot program. And Ryan, while we're talking about the ability to get additional information or additional drug to cover patients not covered in this pilot program, just want to remind folks, if in fact you have a request for that, just let us know. We're happy to forward that process over to you so that you can get drug, whichever product. Actually, if it's outside the pilot, doesn't really matter. You can get those from your state health department or hospital system to be able to infuse those in different alternate sites of care. So if you have that request or you're looking to try to build that, just reach out to us and we're happy to provide that information. We have a question here. Go ahead, Ryan. Sorry, go ahead.
Sorry, it's Bill. I would add that the Medicare coverage is site of care agnostic, meaning it doesn't matter what site you provide the product in as long as you meet the criteria in the emergency use authorization. Our pilot is specific to nursing homes, long-term care facilities. But if you're able to get the product outside of the pilot, it could be administered in the home, an infusion suite. And I just wanted to point out that it's site of care agnostic. The rate is not going to vary. It's still going to be the $309 for Medicare anyway.
All right. Then here's a question just asking about why hospice and palliative care has been excluded from this pilot. I think I don't know that answer to that question. It really was focused 100% on getting the drug to the skilled nursing facilities, long-term care, where they felt at the time that there was just not enough being done in those facilities with the drug. And as Ryan said, this is all brand new for everybody to try to get this type of treatment out. And so we were just tasked with working with them to get it into that program. Again, it doesn't preclude someone from getting drug from another source if it's going to be done for hospice and palliative care, but this pilot does not cover that. I don't know if you have anything else to add on that, Ryan.
Yeah, so I was just going to mention that, let me take this one away quickly because there are some hospice long-term hospice facilities that are set up that way. They're sort of an inpatient hospice facility. And when I came from long-term care, we did have hospice inpatient facilities that we managed and provided medications to, and we sort of grouped it into long-term care. But let me take that one away. I would want to get some clarification on that, Jen. And I agree with you. We didn't really think about it from that perspective. But if there are patients that are receiving palliative care or hospice care that are in a facility, that may fall under the purview if the family and patient and physician would like to give it to that patient. So that may fall under the purview of our program. So let me take that one away. And okay. Rebecca, I think that was you. Let me get some clarification on that one, because like I said, again, if they're in a facility, that may fall underneath this program.
Great, thanks, Ryan.
Home patients, no, obviously, but because a lot of patients do hospice and palliative care at home, but for inpatient, let's take that one away and I'll get back to you.
Okay, thanks. And the next question is a little confusing, so I want to make sure that I've got it right, but it sounds like what the person is asking is, can the SNF and the home infusion provider both bill for the nursing code? And if that's the question, the answer to that is no. one or the other has to bill. So how we've seen it done is a home infusion provider would bill for that and provide the nursing either under subcontract or their own nursing. But we've also seen the skilled nursing facility bill that code, and then the home infusion provider would charge back to that nursing home a dispensing fee. So again, both entities cannot bill for that. It only can be billed by one or the other. So if that doesn't answer your question, Holly, just put something else in the chat there so we can clarify it.
And
go ahead.
I was just going to add, Connie is on the call and I think just listening in, but she did just send me a quick message that yes, based on some of the conversations she's had directly with HHS and Operation Warp Speed and ASPR, that if the patient was in a facility, hospice or not, if they're in a facility, they fall under the purview of our program. So again, if they're in an inpatient hospice or they're in a SNF and they've been deemed hospice and that decision is made to infuse them with a monoclonal or BAM in our pilot, that would fall underneath the purview of our pilot, and that can be done.
Okay, great. Thanks. All right, let's see. Yeah, so again, the both, we get in a couple questions about this, but the SNF and the home infusion provider cannot bill this code. It has to be billed only one or the other. It's a totally different way of looking at things. Might be a little bit confusing, but one or the other can bill that, cannot be billed twice. All right. Again, a clarification on whether this can be given to non-Medicare patients. It can be given to non-Medicare patients, but in this pilot, the pilot drug has to be given in the skilled facility, long-term care, or assisted living. So if those patients are covered by other insurances other than Medicare, you would run through your regular process and the drug can be used for that. It doesn't have to be billed through Medicare. I think another perfect example of that is this pilot does cover staff in those facilities that might become COVID positive. So that staff member may not have Medicare, but that product can certainly be used under this pilot for that staff member. All right, here. Then there's just, I think there's a question in the chat here, Bill, about you can't bill for the drug, just the nursing visit. That's correct. The drug is actually free, so you can't be billing anybody for that. Bill, anything to add on the drug billing?
When it comes to Medicare, they've stated that if there comes a time where the drug is not free and it's a buy and bill scenario, that it would be paid at 95% of AWP. But while it is free, you cannot bill for it and you should not include it on the claim.
All right, then a question, have others found it difficult to have long-term cares that are reluctant to administer? I think we're hearing kind of all over the board. Some long-term cares are, really focused on the vaccine and feel like they don't need the MABs. Others don't have the nursing to be able to do it. So it is kind of all over the book. And then we have some folks who are, welcoming it with open arms and have close relationships. So, certainly feel free to reach out to Ryan and I if you have a specific question on that. But it's really kind of all over the board for sure. All right, here's a question, Bill, I guess, and we may need to take this back. Is the ability to use this drug for patients who are uninsured in these facilities? And I don't know the answer to that. Would Medicare cover that, Bill?
Jen, it's Connie. So I think the way that I would describe this is that the criteria for our program and the aim of our program is to support facilities in reducing hospitalizations of their patients and in helping control outbreaks in facilities. So if a patient is in a facility, that patient is eligible to receive our product. If the patient doesn't have a payer source, which is hard for me to imagine how the facility is then getting paid for that patient, we would probably send us those scenarios so that we can help you work through that. And Bill, you can add your thoughts as well. But I just want to make sure we're clear about who's eligible to receive the drug. The drug can be given to anyone in a facility, regardless of hospice, not hospice, payer, no payer, or payer source. So the drug is eligible. If the patient has no other payer source, which is something we'd have to understand how that would be, do send us those individual cases and we can try to help you work through it.
And I think it just, your point, Connie, just reiterates the fact that we're recommending that you run the patients through your normal intake process. All right, I don't see any other questions in the queue. How about Bill or Connie, do you have any final comments?
I mean, the only thing I would say is I just want to express my appreciation as well. I think
All right. Well, that's it for today. Thank you, everybody, for participating. Yeah. Connie, you broke up a little bit.
Yeah, sorry. I thought I was unmuted, but I think maybe I was partially muted. I just wanted to thank everyone on the call, and for those of you who are participating in this effort, I think it's going a long way to demonstrate the goodwill and partnership we have in the communities that you all serve, as trying to do your part to help control the pandemic. And it certainly is appreciated by HHS and the folks that we're working with. So I just want to pass that on. Thank you.
Yeah. And I think too, for those who haven't been able to infuse any yet, don't be discouraged. Actually, what we're hearing from HHS and the group is that it has a very steep incline. So once you start getting the word out and start having some successes, it starts to go up exponentially from there. So again, they are very happy with the pilot. It's making sure that information and the drug is available, and you should start seeing again more uptick in that piece. So we're excited to have you guys all on board. All right, everyone have a great day. This is recorded and we will email you a recording at the end of the presentation. Thanks so much. Have a great day.